welcome everybody to the third interactive discussion session of the McKenna Health Policy and Lecture Series. This is Matching Supply and Demand. I'm Mike Duke, and I'm a member of the McKenna Advisory Committee. I'll help facilitate today's discussion. And by the way, this will be a discussion, and we want you to be involved in this. So while we do have two very knowledgeable discussion starters who will actually share their experiences and perspectives with all of us, we do want to hear from you. And I'll talk a little bit more about how you'll be able to easily participate in just a second. But first, let's look at today's agenda. Next slide, please. There we go. First, we'll cover how you can ask your question and be involved in the discussion or share a comment. Then I'm going to share a little bit about the background of the McKenna lecture. We'll then meet our supply chain interactive discussion starters and facilitators, and I'll overview some key points about the March 9th McKenna lecture. Then each one of our discussion starters will share their perspectives about our topic, and we'll ask for your comments and questions. First, we'll start with Provider System Chief Supply Chain Officer, and then we'll follow that with a CMO's perspective. And after each perspective is shared, we'll launch into questions and comments from our other discussion starters, our facilitators, and from you especially. So we're scheduled to go 90 minutes, and we will have lots of time to do that. And by the way, if you ask a question and it doesn't get addressed, someone will follow up with you with an answer. So let me start with a little background about the McKenna lecture itself. And actually, it's the McKenna Health Policy Lecture. The lecture was established in 2010 by the Health Sector Supply Chain Research Consortium in recognition of Mark McKenna, who in 2004, along with Dr. Gene Schneller, formed the consortium. This annual lecture has always been an in-person event, and we usually feature a keynote speaker at a lecture, and we also precede that with a networking symposium. This year's lecture, of course, was presented virtually, and it was on March 9th. Today's session is one of 4 interactive sessions intended to provide our participants with that networking experience and opportunity. And by the way, I do need to tell you that all of our annual lectures and networking sessions are brought to you and brought to participants at no charge. These are funded through donations to the Mark McKenna Lecture Endowment. The confirmation email that you received actually has a link to our donation landing page. So please consider making a donation of any size so we can continue to bring this high quality content for free. And by the way, HSRC is now a part of CAPS Research, and I want to thank the CAPS team for their really strong logistical support for this year's event. So I mentioned this is our 3rd interactive session. Our 4th will be 1 week from today, and it's titled A Systematic Approach to collaboration, across pillars, organizations, and sectors. And this session will be facilitated by my fellow McKenna committee member, Karen Conway. So make sure it's on your calendar. You won't want to miss this. So let's welcome and meet today's discussion starters. First, Doug Bowen, VP of Supply Chain Services for Banner Health, and John Scharf, Chief Medical Officer for Lemire. And in addition to me, our other facilitator is Brian Fuller, Executive Director of CAPS Research. Doug, let's begin with you. Why don't you just tell us a little bit about yourself and your role at Banner Health?
Thank you, everyone. And I am Doug Bowen. I'm Vice President of Supply Chain Services at Banner Health. I joined Banner in 2002. Prior to Banner, I served for 17 years in healthcare supply chain leadership positions with Hospital Corporation of America, HCA, and I was in Utah, Oregon, Tennessee, and Texas. My goal as a supply chain leader is to optimize the network value for our patients, our payers, our providers, and our suppliers using a fully integrated supply chain model. Banner Supply Chain has been ranked in the Gartner Healthcare Supply Chain Top 25 for the past 7 consecutive years. And currently, Banner is ranked 5th in the top 25 rankings. Banner has 30 hospitals in 6 states, and Banner Health is the largest healthcare provider in Arizona. And our mission is to make healthcare easier so life can be better. Thank you.
Thank you, Doug, and congratulations, by the way, on your 5th ranking on those Gartner Awards. That's a very rigorous process. I used to be one of the raters, so congrats. John, let's hear a little bit about yourself and your role with Lemire.
Sounds good. Thanks, Mike. My name's John Scharf. I'm calling from Chicago. I'm an orthopedic surgeon who's been in practice for about 25 years, largely focused on disorders of the knee. I'm also the chief medical officer of Lemire and have been in that role for about 4 years, recently acquired by GHX. And I would say my interest in supply chain is multifactorial, but it's sort of the trisection of medicine and public health and sort of the business aspect of making this happen. I think it's an exciting time in healthcare, and as my career progresses, I'm transitioning more away from clinical and more to operational and sort of macro issues, which are some of the things we're going to be talking about today.
Thanks, John. And we're really pleased to have a physician perspective as well. And it sounds like you've got your hands in a number of different parts of the industry, clinically and from a business and supply chain standpoint. So welcome. A little bit about myself, Mike Duke. I just recently retired. I spent 11 years in hospital operations and supply chain, but I spent 34 years with a group purchasing organization, formerly VHA, now Vizient. The last 13 or so years, I was responsible for the educational offerings for our supply chain leaders, and also had the privilege of collaborating to form a very unique network called the Large IDN Supply Network with 20 plus of their largest IDN members. So that's me. But I also had the privilege of working with Mark McKenna for a number of years on various projects while we were both at VHA Innovation. So this lecture and these sessions have a special place in my heart for sure. So last but not least, Brian, why don't you tell us a little bit about yourself, your role with CAPS Research, and I think we should hear a little bit about CAPS as well.
Sure, thanks, Mike. So as you said, Brian Fuller, currently the Executive Director of CAPS. Prior to joining CAPS last year, I have about 23 years or so of experience in supply chain in various different industries. Most recently, before joining CAPS, I was the CPO at MasterCard for about 10 years. So, and appreciate the opportunity. Real quick on CAPS, since you did mention it as part of the HSRC and Jeannie and I working together on this. CAPS is a research center at Arizona State University. And we really have one primary objective, and that's to advance the profession of supply managers. So we work with the Fortune 1000 on the challenges and the opportunities that the supply managers have within their companies, and then how their profession can help their companies succeed in meeting their strategy. So we've been doing this for over 35 years, which means that we have a lot of intelligence, and regardless of where you are on your maturity, we think that CAPS can probably help you. So real quick, just run through on CAPS. We have a great library. As I mentioned, we've been doing it for over 3 decades, and we have thousands of reports, and we're putting new reports in every month. The library is organized. It's a digital library, obviously. It's organized with different tags and keyword searches, and the search function is very robust. One of the other things that you'll see is we do a lot of primary research. That's the link to ASU, as well as other universities and professors that we network through Arizona State to work on the research that our members are looking for. And then what we did send out, so can you go to the next one there, please, Nicole? Yeah, we did send out a maturity model in an email yesterday. This is the digital version. There's up in the right corner is a download. There was a PDF that we did send if you registered for this event. So you will have that to look through. But the intent of the maturity model was to help companies understand, what do they look like? What are the characteristics of their operations, and everything from a reactive posture all the way to being strategically aligned with the organization and the objectives overall. On the next view, we have something that we call the metrics of supply management. This is a series of KPIs and metrics that share an organization's overall effectiveness, their performance, their efficiency. So this is about how the organization is organized and how well they're performing. We have over 700 companies that we reach out to in the Fortune 1000 that respond to this report. So it's done annually, and digitally you can access that data. This last thing that we're showing is what we're calling a metric index. As you can imagine, on different levels of your maturity, how you tell your value story will differ. So we went through all of our research and organized, right now it's about 119 metrics. That's growing every day. We have up to 200 that we're trying to prove out. And this is key metrics with calculations based on what are you trying to report on? Is it just cost savings? Is it quality? Overall process improvement? If your supply management group also helps generate revenue, how do you get credit for that? So these are all things that CAPS have been working on that will help aid the supply manager, again, aligned to their overall corporate strategy. The other thing I wanted to show before I hand this back to you, Mike, is CAPS also works very well with ISM. And we have, I think I saw Nancy Lemaster is in the audience. Nancy is the chair for the Hospital Report on Business. If you're not familiar with it, it comes out monthly, and kind of we're right in the upper right there about the report. It includes a lot of different metrics and indexes that are tracking what's happening with hospitals overall. We did include this in the email yesterday as well. And then Nancy, after we get through some of the other discussions, I think coming back to this and explaining how the hospital PMI and overall report helps supply chain managers in the hospital will be meaningful to come back and talk to. Okay. All right, thanks, Mike.
Okay, so well, Brian, just one comment, and that is that the maturity model looks very familiar, and I think there's a lot of affinities between what CAPS put together and, frankly, a lot of the maturity models that I've seen that have been prepared about the healthcare supply chain, specific to provider organizations and the level of maturity or sophistication of their supply chain program. So I think there's a lot to learn from other industries, and I think CAPS probably provides a really effective way for supply chain leaders on the provider segment, and I think supplier segment, to network with non-healthcare verticals and do a lot of learning. So we're pleased that we're part of CAPS, and I certainly hope that we see more healthcare provider organizations become interested in CAPS research. So thank you, Brian. So as I said, these interactive sessions are more or less hanging off our McKenna Health Policy Lecture, which occurred on March 9th. And just as a reminder, and for a little bit of context, I'll share a very, very high-level overview of the content that our speaker, Dr. Dennis Cortese, shared with us. Dr. Cortese's talk was titled Lessons from the Pandemic, Building a Secure Health System. And he overviewed a collaborative effort between ASU and 8 Phoenix-based provider organizations that he's leading. Here are the organizations, and as you can see, they're very diverse in terms of size, specialty, ownership, and geographical reach. The vision, next slide, please, the vision or mission of their collaborative, which is called the Delivery System Collaborative, is to use their collective learnings to organize and coordinate the healthcare emergency response in Maricopa County, deployment of staff resources and information across the care continuum, and communication activities to the public. Next slide. There are 3 key objectives that they've identified, as we're calling them pillars: supply chain, facilities and infrastructure, and workforce. And by the way, these pillars have been the topical focus of our first 3 interactive sessions. Next slide, please. Now here's a little more detailed look at a few of the proposed goals for the supply chain pillar. First, never want to be in this position again, right? And how do we accomplish this? And can we gain more control of onshore manufacturing? Next slide, please. Now here are some near-term goals of the collaborative. Develop the improvement learnings into actionable plans, understand how this might inform public policy, and of course, implementation of plans. And an important step is to present to and achieve buy-in at the CEO level. And finally, approach the public health sector. Next slide, please. Some longer-term goals, how to sustain the coordination that's established between organizations that have been put into place, as well as changes to the county's emergency preparedness, and how to leverage the learnings into additional research and education, much like we're doing right now. Next slide, please. Now, this is a more detailed look at the Delivery System Collaborative's current discussion topics. I'll let you scan them. I'm not going to review them, and I certainly can't do them justice as well as Dennis did on the 9th. And I believe Dennis is online here with us too. So hopefully we can hear a little bit more from Dennis during the next 90 minutes or so. So next slide, please. We're here to discuss the supply chain pillar though. And we frame that up as matching supply and demand. And we're lucky to have Doug, who, as a matter of fact, Doug's organization, as you might have noticed, Banner Health, is involved in the collaborative. So let's get rid of the slides now. And I'm going to start with Doug. And after Doug has made some initial comments, I'd like the audience, our discussion starters, and you too, Brian, to feel free to ask questions, share your perspectives, and make some comments. So, Doug, we'd like you initially to share from a supply chain perspective how your organization managed its response to the pandemic, and anything, by the way, you can share about the collaborative itself. Doug?
Thank you. And what I'd like to do is just remind us a little bit about how we ended up in a PPE crisis, and a reminder that this pandemic was a worldwide pandemic. In the past, we've had hurricanes, we've had isolated pandemics, we've had other disruptions to our supply chain, but this is really the first global supply chain disruption that we've had. So this was supply chain news on the front page on a daily basis. And the way that events unfolded is that about 85% or more of the world's personal protective equipment comes from China. And China was the leading, the kind of the origin of the virus. And as workers began falling ill there, they actually needed that PPE for themselves. So they reduced their exporting. Then as the workers continued to be ill and not able to work, the production decreased. And so you had this perfect storm of a global increase in demand for PPE and a shrinking supply. And so this perfect storm really hit us in about the spring timeframe when all of this disruption started happening in the supply chain. And so what happened next actually made it worse for us. We had a series of events that combined the problems that we were already experiencing. The problems that we experienced, number one, we have a strategic national stockpile that turned out to be less than 1% of the needed PPE we actually needed. Then we had panic buying. We had everyone buying up PPE. We had middlemen buyers that created a high price gray market, and they were price gouging 10 times normal prices. And then we had this bidding war that was going on, country against country, state against state, right here in the United States, hospital system against hospital system. And then we had also consumers buying PPE for the first time. And so they were taking up portions of the market. And then these middlemen were making matters worse by buying up inventory and holding it, because the longer they held the inventory, the higher the prices they could get for that inventory. And then lastly, we had existing manufacturers that had to put everybody on allocation, meaning that they were only to provide your historical quantities of personal protective equipment. And this was a pre-COVID quantity that had nothing to do with the reality of the day, meaning that, I now need 10 of these and my allocation is 1. So that was not helpful at all. And so all of these things led to a variety of problem solving that needed to happen at healthcare systems. And one of the ways that Banner addressed this is we put together a PPE cabinet that consisted of our senior leaders, and everything that was going to happen regarding PPE was going to be generated there, endorsed there, and executed there. So we had one clearinghouse and one source of truth for all of our facilities to follow. And sometimes the guidance changed from day to day. We had CDC guidance that was changing, and we had to be nimble in changing the way that we operated. But one of the first ideas we brought as we hit the first surge in March was, let's migrate from disposable isolation gowns to reusable isolation gowns. We were consuming 1.3 million isolation gowns a month. That's an entire shipping container every week. And there was just no way for that to be sustainable over the long run. And so we immediately got with some local manufacturers, some fabricators, and they started sewing reusable isolation gowns for us in Tempe and in Mesa. And we designed our own spec. We included Velcro on the back of the neck of these isolation gowns so that they could be easily taken off by our caregivers. And we were able to get these isolation gowns into circulation in time for our second surge, which happened in the summertime. And then, as it turns out, our last surge, which happened December, January, was the worst. But we were also prepared for that surge as well, using these isolation gowns. So we had 2 key strategic pivots in our supply chain strategy. Number 1, pivot to reusables. Number 2, pivot to local suppliers, not global suppliers. And we've been continuing those strategies and will continue those strategies moving forward. In fact, our reusable isolation gowns are a permanent solution. They're not just for COVID. We are continuing to use those as they've been a winner in every category. They've been a better cost, they've been a better quality, and we've had better outcomes. Our caregivers have felt better protected, and it's also a sustainable solution because it's good for the environment, and we put it through the laundry like we do the rest of our patient linens. So that's the key strategies in the way that we address the COVID pandemic up until now. Thank you.
Doug, I've always liked to ask people who have been in, who were a chief supply chain officer, basically the question of what would you have liked to have known on February 28th of 2020 that you didn't know that you realize now would have been really helpful to be aware of?
Yeah, the thing that I always tell everybody is that a supply chain, or any system for that matter, can only perform as well as it is designed. And so we had designed a supply chain to, run at a certain speed and a certain demand volume. And had we known the actual demand for what was going to happen, we could have had time to gear up and prepare and execute. But because we were a bit caught off guard on the significance and the length of time and the volume of supplies that was going to be needed, we were in a reactionary mode. And so we were a little bit playing catch up for a while. And in supply chain, everyone will tell you, if you're working on today's problem, you've already lost tomorrow's. So we really would have liked to have had been better prepared with knowing actual demand so we could have matched that. Thank you, Michael.
Thank you, Doug.
Hey, Doug, it's Brian. Got a question for you. You mentioned you set up a PPE cabinet. They were there to help make decisions and maybe break down bureaucracy. How much time did you really cut out in that decision-making process when you said, look, the way we've been buying these isolation gowns isn't going to work. This is what we propose to do. I mean, how fast did you move?
Yeah, so using our PPE cabinet, we had every key decision maker available. So we had no time lost to go to get, buy-in or approval from a variety of constituents. We had all of our care management folks, all of our hospital operations leader, infection prevention, EVS, culinary services, supply chain, every service line at Banner was represented there, and we were able to make decisions and execute them, overnight. And so I would say, we went from a probably what's normally a week-long decision-making process to a 24-hour decision-making process.
I heard that from a lot of companies in multiple industries, just the implementation of a crisis response team or emergency response team and how fast they were able to make decisions that under normal business would have taken a lot of time. So.
Yeah, and you really appreciate how much red tape goes into a traditional decision-making process when you're in a what I call wartime effort. And when you are in a wartime effort and people are present and everyone is supportive, decisions are quick and the actions are even quicker. So it is a wonderful experience to be able to see that happen in a time of crisis.
Doug, we have a question in chat which looks interesting, and it's from Esma Gel, excuse me. Do you think there's a way to operationalize COVID projection models for prediction of demand for PPEs and other pandemic-related supplies?
That's a great comment. The COVID pandemic really put a great focus on the various models that were available and our ability to put in our current patient census and have a prediction for the necessary supplies that we were going to need. We had models that could handle the number of enhanced precaution patients, which means we were going to be using PPE for those patients. And all of those models were fine-tuned to where they were very accurate. And we were able to, over time, perfect those models to give us very good actionable data, not only for supplies, but also for our hospital operators. We had a capacity cabinet that was able to do planning for 100% capacity, 125% capacity, 150% capacity. We actually had most of our hospitals at close to 150% capacity during the largest surge. And the ability for those facilities to not only add hospital beds, but also add all of the other supporting equipment that you have to have, blood pressure equipment, patient monitoring equipment, IV pumps, et cetera. All of those things had to arrive in order to activate those needed patient beds. And the ability for that data to be accurate was crucial in our ability to respond. Great question.
Doug,
Good question.
this is Karen Conway, and I've got a question based on, I applaud you for that quick move to reusables and for designing fit for purpose, if you will. What I have heard from other organizations that did the shift from disposable to reusable, but did not necessarily design the new product themselves, said that now that disposables are back in relatively good supply, they're finding the clinicians are resistant to continue to use the reusable and want to go back to disposable. How did you manage that? And I guess how much did designing your own product help with that?
Great. So yes, we worked with caregivers to make sure we were producing a reusable gown that they wanted and that they felt comfortable and protected in. And so I think that was the key to our success, was having a product that was superior to the prior product that they were using. And as we were able to have volumes go down, we continue to use those reusable gowns, and they continue to be supported by our caregivers, again, because it is the quality product that they have been used to using and have appreciated it. So I would say that is a key, is make sure that as you convert, when you go from a disposable to reusable, not only do you want to make sure that you are providing a better product into the future, but it also has to be one that is going to be, you're going to have raving fans from your user base. And so thanks, that was key to our success.
Doug, we have a chat question from my friend Nancy Lemaster. Is there anything you learned during your expedited decision-making process that you'll continue to use to reduce your overall decision-making time going forward? So truly lessons from the pandemic, something that you're actually going to leverage to improve processes in the long run, and in this case, decision-making.
Yeah, so one of the lessons learned that we have kept was that at any time that we find something that needs expedited handling, we stand the team right back up ad hoc. Meetings can get scheduled on your calendar anytime now with our virtual way of working. And so this expedited way of getting everybody together to make an expedited decision, that continues moving forward through today. So that is one of the things that is carried forward from the lessons learned. The focus discipline, the collaboration, and the communication lessons that were learned are the three things I would say that were key takeaways from the COVID pandemic.
And Doug, before I ask John to make a few comments, I know it's early in the process with the work you're doing with the other systems, but is there anything to share that you've been able to learn, or anything that's surfaced from the discussions with the other systems, or is it still too early? And if so, that's fine.
Yeah, I think we're just in the storming phase of our group meetings, and we are all on the same page that we would like to be better prepared for any future event that might happen, and the ability for us to identify sources that we could all help each other with as needs are identified, and our ability to execute on getting those supplies to the right area, where whether it's a local hospital or anywhere that we're supporting in the state of Arizona. We'd like to all work together to make sure that we design a backstop for us moving forward, and we'll continue to work on that and achieve that goal.
Well, I hope that CAPS and also our group can learn some more and hear some more about the work that you're all doing together. Competitors coming together to improve things is something that is a hallmark in other industries and supply chain. So again, another learning. They do it. I mean, I think General Motors, Ford, and Chrysler design and manufacture components together because it just makes sense to do that. So we do want to hear more about that over time. But and thanks, Doug. Let me go to John. John, from a physician's perspective, why don't you share some of your observations and experiences as the pandemic unfolded?
Sounds good. Will do, Mike. Listen, my comments will be really from just what you asked, the physician perspective, and less from the CMO of Lemire perspective, but just sort of what I observed over the last year. And I'll put my comments into 4 buckets. Those 4 buckets are sort of the vulnerability of supply chain, some wastes and inefficiencies, the national sort of fortitude and response, and then sort of a balanced future. So let's start with vulnerabilities. I'm an orthopedic surgeon. I've been focused on disorders of the knee for 25 years, and I've taken so much for granted in terms of supply chain. I've had a pretty good understanding of PPI, physician preference items, and that I've always had a relationship with my reps. But I've walked into an operating room for 25 years with an expectation that it's going to be 100% perfect every day, and really not given much thought of what it takes for that to happen. And that could be, you know, starting with putting on a mask at the scrub sink. So the COVID, sort of the pandemic, underscored how much I've taken for granted as a clinician, and I think many of my colleagues would say the same thing. So first, the assumption that everything's going to be perfect supply-wise, I think the pandemic showed some gaps and some vulnerabilities. As Doug mentioned, there were a lot of people scrambling for PPE. And I would say as a physician, it made me very uncomfortable recognizing my success in having the supplies I wanted came at someone else's expense, meaning there's a zero-sum game, right? There was a period of time for months where there were limited supplies, which everyone's scrambling for. And as a clinician looking out for my patients and for society, I felt very uncomfortable, almost hoarding material, because again, if I have it or if I have access, someone else doesn't. And that was a pretty unique, bad feeling that I've not really experienced in my career. So on the vulnerability front, you know, the takeaway is I think myself and most clinicians have a lot more respect and a lot more interest in supply chain. Supply chain has always been sort of a sleepy, boring topic amongst physicians. I'm being candidly honest, and it's no longer that way, meaning the topic of supply chain is so prevalent in our literature today and in our conferences, it's really top of mind. And one of the silver linings of this will be that that's exactly what we need. We need clinical engagement and interest as we proceed down this journey of a clinically integrated supply chain. So to me, one of the silver linings of COVID-19 is going to be the awareness for physicians to be in the supply chain game a lot more than they've ever been in the past. Not only for people like myself who have sort of an endogenous interest, but I think all of my colleagues, it's a topic that's easy to talk about. And I think we'll do a much better job managing forward. The second bucket is sort of the waste and inefficiency. You know, there have been a lot of things done that are probably non-scientific, and I really question the value. And I'll talk about just some basics, like the concept of masks. Initially, masks aren't necessary, then one mask, then two masks. How do we differentiate from masks? Is my mask better than all the variety of masks my patients come and see me in my office? If you go to Amazon, you can get a variety of masks, right? So there's sort of a lack of rigor, and I'm not, to this day, I'm not sure what the ideal masking is. I'm also not sure what the long-term sequelae are of people wearing masks, you know, 12 hours a day, 5 or 7 days a week, meaning how does that affect our pulmonary system? I look at temperature. Every day I walk in the hospital, my temperature's taken. The inter and intra variants of those measurements are remarkable. So on cold days, when John Scharf walks in, I live in Chicago, I'm hypothermic. A number of days I'll ask him to take my temperature twice within a minute, and it's different. So we've tied up human capital. We've used supply chain items, which I think have a lot of variation in terms of their accuracy. Another example of inefficiency. On a larger scale, as we ramped up, as we saw some pretty dramatic images from New York of shortages of beds, you know, I think we overreacted. So in Chicago, for instance, we converted the McCormick Center into a facility that could house patients at the cost of about $60 million. A handful of patients used it, and it was probably never necessary. Go ahead and fact check me, but I think there was a similar experience at the Javits Center in New York. So in the best of interest and the best of intentions, on the one hand, we're really struggling with certain supplies. On the other hand, we're using some non-scientific and maybe overreacting and deploying a lot of capital in a very irrational way. So my takeaway on the waste and inefficiency was that there was probably an overreaction. Some of it relates to supply chain. You know, hopefully if this happens again, we're a little more scientific. And I think that's another thing we're going to see in supply chain is again, clinically based, more scientific, less variation. Takes me to my third observation was sort of the national fortitude. It was a year ago now, roughly, that we were told it would take 7 or 8 years to manufacture and test the vaccine. So everybody on this call knows what happens. We did it in 8 to 9 months. Today, there are multiple vaccines in the market and probably more to join the market. There was a similar example of ingenuity with ventilators. I think there was a very big concern early on that we were going to have a shortage of ventilators. And it wasn't, today we have hundreds of thousands of excess ventilators, meaning I think that problem was largely mitigated. My takeaway from this is, like, don't ever underestimate or bet against sort of American ingenuity and productivity. We're best of class. And even with almost a centennial event, meaning this pandemic, this type of pressure on the healthcare system is the first, probably for anyone on this call, or the most significant for anyone on this call, and maybe the most significant going back to H1N1 earlier in the last century. So I wouldn't bet against Americans solving tough problems. And then the last bucket I'd like to talk about is sort of this balanced future. And what I mean when I say it is about 3%, plus minus 3% of the population was adversely affected with COVID-19. And it was a bad bug. And I'm empathetic for the morbidity and mortality that it caused. As healthcare providers, there were there's another population, the 97% that were not adversely affected. And as we enter this post-COVID-19 era, our hospitals and health systems are going to need to get back to sort of a more normal business. And really the hope is that we have a balanced future and that we don't overreact, and that we take good lessons learned from COVID-19 to be better prepared for not so much similar events in the future, but just better managing supply chain, better understanding, what's upstream, what our vulnerabilities are. As I look at supply chain in the future, there's such an opportunity for health tech to solve a lot of problems. And as a clinician, I can tell you, I'm a little bearish on health tech because my first foray into this was electronic health records, which have been the nemesis of my career, right? Most physicians are not particularly excited about that first wave of health tech. The next wave of health tech is going to have remarkable impact on healthcare, and I think on supply chain as well. And I think that's very exciting. So I guess my takeaway from this is, as a clinician, it's put supply chain front and center. I think as organizations, we're going to have much different conversations with clinicians as we talk about the clinically integrated supply chain. And I think we're all going to look at supply chain differently than we did prior to a year ago. So those are sort of high-level comments from an orthopedic surgeon, and I think it's consistent with many of my colleagues.
Hey, John, it's Brian. I got a question for maybe a statement of confirmation, and then I'll lead into a question. It was interesting to hear you talk about the masks, and then in general, from just a supply chain perspective and working with a lot of other industries. I think last year, if you think of startup companies, last year I think was probably the rise of the low tech startups and how many individuals were making masks in their garage and not computers, right? But you bring up a good point. I think maybe about standards and standardizing specs and different things like that. Do you see kind of what we've gone through and not being able to find maybe the preferred product and substitutes maybe not being proven out? Do you see some standardization even in your orthopedic world? Do you see some standardization coming on various products, or do you think there's a long way to go before that happens?
I think we're going to see so much standardization and mitigation of variation in all aspects of healthcare. So, some of the other hats I wear are with national organizations that are really looking critically at clinical practice guidelines and utilizations of technologies and drugs and devices. The bookends are pretty wide right now. Those bookends are only going to get more and more narrow as everyone's career progresses on this call. So to answer your question, yes. And I think there's some sort of heuristics and norms out there that can be challenged, right? And maybe COVID-19 forced us to not have everything perfect, but still have pretty good outcomes, right? So reusable gowns or PPE. I mean, I think some things that we felt very uncomfortable in the past irrationally, we're going to find that maybe we can do well with less. Does that help answer the question, Brian?
Yeah, thank you.
Mike and Brian, we have a question in the chat asking about the discussions related to domestic manufacturing or nearshore manufacturing. I'll just read it. There's been a lot of talk to avoid such supply chain issues in the future. Is this really a viable long-term solution, or will fundamental economics drive us to realize that global sourcing is still the best way?
I don't know if anybody has a real good answer for that. I have a personal opinion, maybe. And it was actually, that question has come up a lot. It actually came up even at the start of COVID. I remember when I was still at MasterCard, people were thinking, well, there's going to be a huge outflow from China. And we kind of did see a little bit, maybe not in the hospital and medical side, I'm not quite sure, but in general, with some of the tariffs, we already started to see some move out of China, but not back here, not to the US. And so my personal opinion is until maybe costs aren't the biggest factor in a lot of things that supply managers and companies look at, I think we're going to continue to chase low cost country. And I think that's going to be the biggest driver. Now, you put in, I think, risk and the ability to assure supply, that starts to become a bigger factor. In fact, we're actually doing a research paper that looks at if you had to make the same sourcing decisions today, knowing what we've gone through, compared to the sourcing decision you made 5 years ago when you decided to put your manufacturing there, would you have made the same decision? And so we're looking at what variables are becoming a little bit more prominent. I still expect cost to be right there at the top, but I think maybe total cost starts to have a better factor, and you start building in maybe risk a little bit more. But I think unless it's regulatory, regulations drive us out, I don't know. We've seen some move out, and maybe Nancy, maybe you've seen more, but I think it'll be slow, personally.
Muting. There we go. Yeah, I think that, in talking with some of the other healthcare providers, they're very torn between, the message of we need to be better prepared, we need to do a better job at demand planning, and we need to be looking at, more onshore product. And oh, by the way, can we cut costs by 10, 15, 20% because, we lost all of this money taking care of COVID patients. So, I think it's going to be, some of it's going to be dependent on the government and how much money they put and incentives they put in place for manufacturers to reshore some of those operations. Historically, we've had very short memories when it comes to pandemics and downturns, and haven't done a good job of learning lessons. So I'm hopeful this time will be different. And I think truly the ongoing cost related to the logistics and bringing product from overseas locally is increasing and is having an effect on the formula. So, I want to be kind of cautiously optimistic, but I don't think it's a slam dunk that, given the pandemic, we're going to see a huge wave of manufacturing moving back to the US.
Yeah, I think too, Karen, and I think that question may have come from Jim. This isn't unique just to this industry. I mean, the news every day about a lot of the consumer products, the retail sectors, just shortage of shipping containers because we just can't get product over from China. We've got the semiconductor issue, which is impacting the auto industry tremendously, and quite a few others. But I think that there's this whole matching of supply and demand. There's a whole rebalance of a lot of economies that have to happen here.
I think that's a really good point, Brian. I was on a call with the MITRE Corporation this morning, and we were discussing this very issue. And one, that it's, we need to look at it from healthcare is not the only supply chain that's struggling with this question. And perhaps there are ways that we could partner, collaborate with others, particularly if we're looking at opportunities to invest, for example, in flexible manufacturing, which would make it much easier to switch one line to another product. I mean, we required that under the Defense Production Act, but that doesn't mean it was easy. Could we plan to be much more flexible? I mean, I'm thinking, you know, Doug going out to apparel makers and coming up with a new product. It is that kind of collaboration. The other is, can we consider things like, can we try to solve multiple problems? You know, can we create tax incentives for those kinds of investments for manufacturers? Can we provide some kind of incentive for the hospitals to be buying domestic products? Can we be solving a problem such as the social determinants of health by investing in manufacturing or warehousing in disadvantaged communities? And also, can we work more closely with our near partners? You know, I know Canada's having a lot of discussions, and Jim might want to weigh in on this, around, you know, a lack of manufacturing, and, you know, should they solve it, or is there a way that we can work together? Same way, you know, we're starting to send, I believe, the AstraZeneca vaccine down to Mexico because it's approved there and they don't have any. You know, can we work better? Can we work differently?
I have a general question, maybe for the audience, if anybody knows, and maybe Nancy comes back to you. But, you know, we think of managing supply and demand, and I think we think of tangible products. But what about on the labor side? I mean, I know, Doug, did Banner have a labor supply chain issue and not having the right expertise when you needed it?
Yeah, we did. And before I answer that question, I did want to tag on to the earlier thought about domestic manufacturing. As we all know, we tend to do what we get paid to do. If we're incentivized to save money, that's what we do. And unfortunately, as supply chain community, we have been incentivized to chase pennies to China over the last several years. I used to live in Dallas, just a couple of miles away from a manufacturing plant called Technol. At the time, they were manufacturing about 70% of the United States surgical masks. And over time, the supply chain community started finding that they could save pennies as they bought global product, and Technol quickly lost market share over time. And the domestic manufacturers are worried about the same thing happening today. And so what we have done is to make long-term commitments, 4, 5, 6-year commitments to domestic manufacturers to give them the comfort, you know, the knowledge that this is a long-term commitment and you can find ways to be efficient and compete with the other countries. And so I am one of the folks that is dedicated to supporting domestic manufacturing and making this a permanent change, not a short-term switch. So we're finding ways to buy domestic gloves, domestic everything, all products. So that's a big pivot that we have decided to make. And as part of that, discussions have to be had with senior leaders that, hey, supply chain needs to be judged on more than just cost moving forward. We need to be judged on our resilience, on our risk management, on our quality, and not just cost. So we got to change the conversation in the industry away from cost and towards a total ownership cost that includes all those other factors.
I've got a question on that note. So when we look at markets, do you build or buy, right? And we saw some health systems get together and talk about making generic drugs a few years ago. Do you think large systems, either independently or in consortiums, have an interest in building as opposed to buying, meaning taking ownership and being more vertically integrated with some of these supply chain issues? What are your thoughts?
I do agree. We're trying to run as vertical a supply chain as we can. And so I think there are a lot of health systems that want to be involved in a vertical supply chain and being a participant, a committed customer of whether it's drugs or medical supplies or equipment. And I think that model offers a lot of possibilities for growth in the future. That's just my opinion.
I think
Doug,
that
this is Gene Schneller. you know, as we all know, the Strategic National Stockpile failed miserably to perform in the midst of COVID-19. And recently, the Biden administration's put out several major papers on resilience in the supply chain and discusses much of the things we have. If you all haven't looked at them, they're really worth scrutinizing. But we've also seen some states put in some new regulations, California mandating 90 days of supply. And I just wonder your thoughts about those kinds of mandates and where they should come from. And, you know, some of what we're trying to do here in Arizona is buffer that by really having community think through about the best way to achieve those goals. And wonder if you could share some of your thoughts on that.
Yeah, I'm a fan of Ronald Reagan and his quote that government is not the solution to our problem. Government is the problem. And so I am not happy with what's going on in California. And I agree with you that our communities can do a much better job coming together and solving problems without mandates that create a variety of unintended consequences. As we looked at our supply chain, we had, you know, you'd try to solve a problem one way and you would create a problem another way. For example, we went through a process of instead of using PPE, let's move our IV pumps right outside the door and have long IV tubing. And that way our caregivers won't even have to go in the room. And that was immediately acted on. And within 24 hours, we figured out we're not going to be able to buy enough long IV tubing to sustain this practice change. So we had to scrap that. And so I just wanted to, you know, make a point that everything that we do sometimes has an unintended consequence. Open to others on government involvement.
I'm curious with the audience, is there any concern that there could theoretically be too much government intervention post-COVID-19? Meaning, a big pandemic doesn't happen often. Is it possible that we could overcorrect, or there might be more heavy government compliance for the future? Is there a concern by those in the audience?
This is Stefan with Tenant Health. I think we can share the new Assembly Bill 2537 that California recently released. That there's this mandate about having certain levels of inventory, and so now they're mandating specific inventories on specific products that have to be carried by the hospital. So as opposed to allowing the supply chain to optimize the supply chain and make sure that the caregivers have what they need where they need, they're requiring it to be certain products, certain places, certain ways, which just puts it onerous, and it could create limitations, and it could de-optimize the way that we're going to operate our supply chain. So I would say yes, that the government could certainly step in and de-optimize the way we can build things.
Stefan, I'm with you. My fourth bullet point was just that, sort of this balanced future, like what can we learn and not necessarily overreact? Is anyone else experiencing concern about government intervention that might be beneficial or not beneficial in the future?
This is Dick Perrin. I'm going to chime in and add a couple of perspectives. One is in terms of crossing state lines, John, for certification and clarification of physician capabilities. When you get into the telemedicine domain and you go across one state line into another state line, and your certification comes into play, and that's slightly outside the topic of supply chain stuff, but nonetheless is one that I'm going to be very interested to see what happens with that going forward. The second topic that I'm starting to hear about is everybody should be carrying a national ID card with their record of their vaccination on it, which certainly gets into issues of information and personal information security, and sort of smacks of violating HIPAA requirements along the way. So those are just two thoughts. Back to you.
Let me follow up on your physician workforce comment. So you're absolutely right. This concept of the corporate practice of medicine. If you cross state lines, are you credentialed? Are you insured? And when we talk about telemedicine, what's the home turf? Is it where the patient's at? Is it where the IT's at? Is it where the physician's at? As an anecdote, the American Academy of Orthopedic Surgeons fought for years, and were successful about a year ago, to have traveling physicians traveling with their, say, intercollegiate teams to be able to take care of their athletes out of state. So if I'm taking care of Northwestern and they're playing Wisconsin, it was very difficult for me to practice medicine with my team in Wisconsin until this changed. So when we talk about supply chain, we could also talk about human capital. I think there's huge opportunity to the point you just made. Like, what's the venue? Where are you credentialed and where are you insured? Really good point, Richard.
We also have a raised hand from Eric. Eric, if you want to unmute, there you go. Ask your question.
I'm Eric Suzanne from the Mayo Clinic, and I manage the pharmaceutical supply chain. John mentioned sort of non-for-profit companies making generic drugs, and we're a member of Civica RX, and we started with them from their founding. And we have found that model has been helpful for us, and we think that one of the reasons why we had less problems with pharmaceutical supplies was because that actually did get up and running prior to the pandemic. And we've seen that it's caused some additional behavioral changes with other suppliers in the marketplace as they are competing with Civica. Civica is providing like 6 months of safety stock and doing some other things to ensure that you have competitive marketplaces and not have all of your manufacturing in one region of the world. So I think that's a good example of a public-private partnership that is starting to show signs of success. And the government has helped with that because they literally did write a check. BARDA is providing $350 million for Civica to build manufacturing plants in the US. So I think that's a place where government can be helpful, where the the hospitals or whatever the industry is can sort of make the decisions about what is produced, and then government can provide the funding to accelerate the progress.
Eric, so you mentioned this is in the nonprofit space. What are your thoughts on traditional non-for-profit systems, maybe managing supply chain in the for-profit space? So not uncommon for a lot of big systems to have investment arms. I think it's common knowledge in Chicagoland and or Illinois, Wisconsin. Advocate Aurora Health does that, and they're interested in investing in health tech. I'm curious, what are your thoughts on doing that in the for-profit space, and does that put your non-for-profit status at risk?
Well, I think that does work. Mayo Clinic does do a lot of those types of ventures as well. Civica is interesting because there are for-profit members of Civica, so HCA and Trinity and others are also members. So it's kind of a mixed bag, but definitely putting the capital where it will work out is a good move. And yes, if you can put it in a for-profit space and generate some additional net operating income, that's always a positive outcome.
Thank you. I've got a question for the audience. So I think we talked about physician awareness of supply chain. So is that a rose or is that a thorn? Meaning, do you want docs and clinicians in your space? Or would you rather have them elsewhere? Complete silence.
Well, my experience has been that you do want them in your space. You want them to be a part of the process of identifying what are the specifications, what kind of products do you need? I had a mentor that came from Bowen to help fix, quote, quote, the healthcare supply chain. And he kept saying, well, what are the specifications? And the physician kept saying, well, Medtronic's the specification. He kept saying, no, like how big and, the metal. So I think there's a real important place for that collaboration on what it is we need to get, that insight, et cetera. And then just like anything else, there's going to be a piece of it that probably that's not the best use of a physician's time when you start to get down to how are you placing your purchase orders and what's the infrastructure to make it all work. So, the collaboration and what I hear from a lot of other healthcare providers is really critical. I think the key is to make sure everybody's really clear on the roles and how decisions are going to be made.
Yeah, I think that's a great point, Nancy. The roadmap's unclear, but the direction is not. The direction is clear. So yeah, thanks for sharing that. Any other thoughts on physician?
Yeah, so John, a few years ago, we did a project of this on CAPS research, and you can go on, and Gilbert Niega and I are the authors of that. And we looked at other industries. We looked at the aircraft industry. We also looked at automotive, and we looked at major construction. And one of the key and all of those have professionals. Somebody at GM pointed out that, if you have 5 engineers and they're developing a new Corvette, each one of them likes different tires to go on that. At some point, we have to make a decision. And so what we saw across those industries is that there were roles where you could bring the professionals together, but they were really intermediaries to the supply chain where a decision got made. And I know Jimmy Chung was on that, and Jimmy has done some of that at Providence. And I think it's really having a governance system around supply chain decisions, especially at the PPE level, that hasn't existed in most systems.
And speaking of Jimmy Chung, he's got his hand up. Jimmy, can you unmute?
Yeah, thank you. I guess I did have maybe an answer to Dr. Scharf's question, and that is that maybe we need to stop thinking about my space and your space. And part of the work that I've been really trying to focus on is how do we create a common space where physicians and supply chain come together, sort of reimagine a different kind of team that really looks at the patient as the ultimate customer of everything that we do. And so I think it's a difficult model for us to consider. I think it sounds good in theory, but we do have, everybody has physicians in their supply chain space at this point to some extent. I think the question more is, do we bring them into, which spaces do we bring them into, and at what level of decision-making processes are they involved in? And I think, reinventing a space where we all work together. And I think we saw some flavor of that during the pandemic, when all of a sudden physicians were brought in to make decisions about, gloves and masks of all things. Like we never had to worry about those kind of things. And so it's possible and we can do it. I think it just needs to be much more intentional. And I think we have to perhaps think about how we change our data analytic process so that we are looking at patient and clinical outcomes as a common metric, as opposed to, okay, physicians, you've got your metrics, and supply chain, we've got our metrics, and let's see if they match. I think there's a way to do that more efficiently as a team. One thing that I wanted to maybe answer earlier about the government question, I think there is we do need some government involvement in various things. I think one of the consequences of, for example, having allowing a free, diverse source of N95 masks, for example, results in the need to do to repeat fit testing every time you use a new brand. And I think I was on a call recently where we asked the FDA about that, and they said, "Oh, that's not our thing. That's that's NIOSH." So clearly, the government agencies aren't really talking to each other, and they admitted that they don't. And so there's a lot of potential there where I think we can really bring real world issues to the government, and they can work a little bit more efficiently to help us out. Because there's probably really no clinical evidence anywhere in the healthcare arena where N95s have to be refitted for every new brand, every person, individual. So that just makes it much more inefficient, for us to use, and also makes it difficult for us to take advantage of a diverse market. And so, and then also one of the reasons I think I mentioned earlier why when we set up these temporary hospitals and they weren't being used, a lot of it was because people couldn't agree on what kind of EHR we're going to use. Are there going to be issues with payment systems and things like that. And there were all these regulations that had to be put up that prevented caregivers from using those reinforcements rather than just building it on their own campus. And so I think there's still a lot of work that the government can do to help us do our jobs better, and we have to make sure that they're aware of it.
We've got another hand up. Jen, you unmute?
Yes, thanks, Karen. They say that with every cloud, there's sometimes a silver lining. So for those of us who are optimists, we might want to look at this. Shortly after the pandemic started, I was talking with a chief of internal medicine at a mid-sized teaching hospital. And she said to me, I never used to think about supply chain, but now I see how important it is. Now I see what's going on. So we've got this opportunity in front of us, both as supply chain folks as well as medical team, clinical staff who can appreciate this. How do we get the conversation started? How do we start to build these relationships so it can be more sustaining? Gene and I and others, Jimmy Chung and others, have been looking at this for a number of years, and we've really struggled because the organization, typical hospital organizations don't lend themselves to this. But there's clearly value, and how do we bring this together? So that's the question. What are the organization models? What are the incentives? What are the roles for each of the various parties to play? Some important questions, and perhaps we can get some dialogue going on that.
No, Jim, that's a great question. I would say, my personal experience is try to speak the language of physicians, or understand the attributes of character of physicians. So they're typically quick learners, empiricists, data-driven, pretty proud of themselves / competitive. So I think providing reliable data in a consistent cadence that offers some benchmarking and comparison is a really good start. And I think the end point should be looking out for the best interest of the patient in the most value-based manner. So it's somewhat about economics, but it's really, I think it resonates when you talk to physicians about what's best for the patient. But another silver lining, I think, of COVID-19 is physicians realize that there's vulnerabilities in their practice. So, for instance, we did a survey of orthopedic surgeons in Illinois, and the average orthopedic surgeon's income was down 30+%. Very few practices died, very few closed, but there's been enormous economic pressure on clinicians, particularly in private practice, more so in private practice than hospital employed. So I think physicians are not only acutely aware of supply chain issues, but also the economics of healthcare is vulnerable as well. So I think talking about a clinical conversation and a financial conversation as it relates to supply chain is fair game. And I think those can be very productive conversations, probably more so today than they would have been a year ago.
So,
John, this is Gene Schneller again. I wonder, we've tried very hard to convince GME programs to include some level of supply chain focus within the residency programs. Orthopedics, where you live, obviously having a second-year resident being involved in the choice of products and looking at those products and understanding the supply chain would be key. We've really failed in that argument consistently. I wonder if this is the time to reinvigorate it.
So that's a great question. Gene, I'm going to follow up with you on this, and I'll give you an anecdotal story about that. So I've been very keen on these economic content in our curriculum, right? And for years, no one wanted to buy it. So within orthopedics, when you're a resident, you take an exam every year. It's called an in-service exam. It sort of measures how you're doing in terms of knowledge, essentially. And then we have to take our boards to be board certified. So for probably 10 years, I've gone to the board to put the content on our board certification, which would make it more important to the curriculum. The boards have zero interest. Probably about 2 years ago, I got our academy to put it on our in-service exam. So right now, about 3% of questions on the annual orthopedic in-service exam relate to typically economic issues. Now, and I frequently write many of those questions. So what I'd love, Jane, is maybe you and I can connect and write some content, write some questions that might be used to test residents. And once residents are being tested on things, it captures the attention of directors because they want their residents to do well on these in-service exams because it's sort of a proxy of how good their training program is. So I love your thought about getting this in the curriculum, and the way of doing it was to make it part of the formal standardized testing. So I'd love to follow up with you, and maybe we can come up with some questions. I can certainly shop them with the American Academy of Orthopedic Surgeons, but perhaps other specialties might have an appetite as well. It's really a good question. How do you get this
Please
stuff?
do that. We shopped the proposal at ACGME and did an article for academic medicine. It was rejected in 7 hours. So obviously it didn't go out for peer review, but it's one of those unpublished things I have a file on. So I'd be happy to share it.
Gene, I think the only reason the American Academy of Orthopedic Surgeons did it on the in-service was like just to get me out of their hair. I think that it was like, we got to get Scharf off our back. Just give them a few questions. Yeah, you have to be persistent.
Just a quick comment regarding, we've had the discussion regarding government's involvement. A shameless plug for a week from today. Our fourth and final session will be looking at the discussions that we had, well, obviously in the lecture from Dr. Cortese, and then the 3 interactive sessions we had each week since, which has been on infrastructure and facilities, on healthy workforce, and now on supply chain. We're going to look at kind of the interdependencies between those pillars. For example, you might have the product, but you don't have a clinician capable of using the product, et cetera. I mean, we've got a lot of interdependencies, but we'll also be looking at models, whether that's a not-for-profit model, a public or a private, et cetera. I would like to make one comment related to the question that Dr. Scharf asked about, do you want the physician in the supply chain? As some know, I've been doing some research over the last few months around the vision of a clinically integrated supply chain, or what I call clinical supply chain integration. And it really is coming around more to that common space that Jimmy's talking about, where instead of one coming over to somebody's house or vice versa, getting around the table, working with data, looking at things, because you could do, metrics around efficiency, equitable, ease of use, safety, reliability, quality, risk. All of those can be viewed from a clinical perspective and a supply chain perspective. Maybe we look at it holistically and we have those kinds of conversations. I think the critical part is there was a great recommendation in a Gartner publication recently, really encouraging supply chain people, go to Gemba, go to where the physicians work, go to where the clinicians work and watch for their pain points, et cetera, and understand when somebody says, well, the evidence might say that this is just as good as that. Why does the doctor feel that this glove or this tool, et cetera, feels better in his or her hands? Is there actually a reason why it's impacting care? Those kinds of discussions. So hopefully you will join us next week as well.
Thanks, Karen. I do, if we could, Nancy, I want to come back to you on the hospital PMI, because we did include it, and I know ISM is looking for people to continue to participate on a monthly basis. And your previous role as the VP of Supply Chain at BJC, how would you have used, or how do you at ISM envision using the hospital PMI? Where's the value from a supply chain manager that you would get out of it?
So I think one of the things that we learned very clearly, or had reinforced, it wasn't that we didn't know it, was how incredibly important it is for today's supply chain executives to really understand the broader, more global impacts on the supply chain. It, as Doug talked about, one of our first times going through a global supply chain. And so understanding how different industries are connected and how they could impact the availability and the flow of the supply chain. So I think, you know, in the hospital report on business, some of the things that it helps give people some insight into is beyond your own local experience, what is the country as a whole looking like in terms of things that are impacting demand, as well as, you know, what supplier performance look like, what are pricing trends looking like, and equally important, what are we seeing in terms of raw material and inputs that could have a ripple effect and give us a heads up that we ought to be doing some of that planning. We ought to be thinking about how we might want to adjust inventories based on that. I think, you know, one of the challenges that Doug mentioned and is really critical is what we haven't really learned how to do yet is to react any other way than by hoarding. And that's not going to help make it better. But I think the insights and comments from the panelists that participate in the survey, and one of the carrots that ISM provides is if you are a panelist and you provide data to the report, you get a full copy of the report in return, and that was provided to you ahead of this. So we think that the report is, you know, relatively young compared to the manufacturing and service reports. The manufacturing report has been out there since 1930, but we do see ever increasing ability for it to be yet another piece of knowledge that can really help the executives better manage their supply chains.
I think you did hit on something. It's some of the other parts of the supply chain. So if you look at what's happening with oil refinement now and some of the shortages based on the Texas storms is having a downstream impact on plastics, right? And some other refined oil products. And then we know where metal prices have been going. So all of that, I think, eventually starts, and then maybe the semiconductor shortages come into the electronics that the hospitals need. So I think, Nancy, you and Tim working on the manufacturing index are trying to kind of pull that story together, which I think is reasonable and needed to be in there to understand the downstream impacts.
Right. So we would, Brian, is there a contact if anybody is on the call today and they're interested in participating that you'd like them to reach out to?
Sure. They within the stuff that we did send out, we did put a cover sheet. I did share it in the beginning of the presentation, but we also put that cover sheet right before the actual report that you provided us, Nancy. So it's in there. It's Michelle Rusk's name would be the person to get a hold of, and again, it's on the title sheet.
Thanks, Nancy. And you know, we have 5 minutes left, but one thing that this reminds me of, and also Jim Eckler's comments about the silver lining led us to a very appropriate discussion about engaging clinicians, supply chain engaging clinicians. But Jim's challenge has another part to it. And Doug, you actually reminded me of that when you said you do what you're paid to do. So the other stakeholder, I would argue, key holder to this is the C-suite in terms of advancing the importance of supply chain. Now, Doug, I'll ask you, I'll put you on the spot. I mean, obviously Banner being recognized in the Gartner work tells me that there's an awareness and an investment in supply chain at Banner. You came from a corporation that obviously has always seen supply chain as a worthwhile investment. So what has to happen? Maybe not so much at Banner and the large systems, but the medium-sized hospitals and the profession overall. What's that conversation with the C-suite need to sound like, and how do we educate them?
That's a great question. You know, my approach to this is just to continue to remind our senior leaders about the value that supply chain brings to the organization, not just in a cost perspective, but also from the quality side as we tie surgical outcomes of products that we use to be able to identify those that are using the products that have been proven versus those that are using other products with poor outcomes. The identification of variation and the elimination of variation is a key to delivering quality care. And so supply chain can play an important role in that whole process. So again, moving the conversation away from cost and towards how do we make this organization a better clinical provider of quality care? And I think that's a part of it. During the entire pandemic, our tagline was that we are going to keep our caregivers relentlessly safe so that they can do what they do best, save lives.
Good tagline. Thanks, Doug. John, any comments from you about the C-suite? Obviously, you've dealt with them. What can we do to kind of get them thinking differently? Because I do think they need to think differently about supply chain. It's not about price, and it's not about getting supplies in a desperate situation.
No, great question, Mike. I think it's a sweet spot of value-based care. So it's another way of saying cost and quality. The market's headed in that direction. There's going to be a lot of transparency and consumerism. I think as a C-suite looks at changing site of care and change in reimbursement, it's going to be impossible not to look critically at optimizing supply chain. So I'm really bullish on what's going to happen with supply chain. I think, we're going to look back 10 years from now, and what we're doing today is going to be rudimentary towards what's going to be happening in the future. I think there's great opportunity and huge opportunity to pursue this journey of value-based care.
Thanks, John. And unfortunately, 90 minutes just flew by, right? So it's 29 minutes after the hour. I need to thank Doug Bowen. I need to thank John Scharf. Brian Fuller, thank you. Nancy, thank you for chiming in. Jimmy as well, Jim Eckler, and our able-handed hand-raising expert, Karen Conway, who will be hosting the next and final session, interactive session, next Thursday, April 1st, where we'll tie all the pillars together and figure out where we go from here. In the meantime, thank you to the audience and again, CAPS Research for your support. Y'all have a great weekend coming up, and thanks.